Hello, ladies and gentlemen. I am Young-Seok Lim, the Program Director of APASL Hepatology webinar in this year. It is my great pleasure to open this month's webinar with the title of Updates of Management for Cirrhotic Complications. Beginning with a very interesting case presentation, world-renowned expert speakers will discuss about the recent hot topics in the management of patients with cirrhosis, including infections, hemostatic abnormality, portal vein thrombosis, and also radiological interventions. First of all, it is my great privilege to have the opportunity to introduce the chairpersons for today's webinar, Professor Han-Chi Lin and Professor Dong-Jun Kim. Professor Han-Chi Lin is currently the president of the Taiwan Association for the Study of the Liver, TASL. He is a senior attending physician at Taipei Veterans General Hospital and a professor at National Yangming Chiao Tung University School of Medicine in Taiwan. Professor Dong-Jun Kim is currently the chairman of the Korean Association for the Study of the Liver, KASL. He is a professor at Hallym University College of Medicine in Korea. I wish all of the panelists and attendees to participate actively to the discussion. Please use the chat box at the bottom of the screen to send us your questions and comments. Thank you very much. Professor Han-Chi Lin and Professor Dong-Jun Kim, please.
Professor Han is not appear here yet, so I would like to start. Dear colleagues and distinguished speakers and honorable delegates of APASL, I am very pleased to welcome you all to this APASL webinar entitled Updates of Management of Cirrhotic Complications. In recent years, there are marked progression in understanding the pathophysiological background underlying many complications of liver cirrhosis. The systemic spread of PAMS due to leaky gut syndrome and DAMs released by liver activates immune cells to produce systemic inflammatory condition. In addition, it was recognized that the clinical course of liver cirrhosis is not linear, but punctuated with episodes of acute deterioration. To define the dynamic syndrome, which is characterized by very high short-term mortality and rapid reversibility, the term acute and chronic liver failure has been introduced recently. This webinar will bring eminent speakers to discuss the latest controversies and issues on infection, hemostatic abnormalities, portal vein thrombosis, and finally radiologic interventions. We are delighted to have a galaxy of speakers here, 4 of them lined up with excellent presentations. At the beginning, Dr. Won-Muk Choi, he's one of a rising star in Korea. Please remember him. At Asan Medical Center and Ulsan University, we'll present an interesting case of cirrhosis with sepsis, coagulopathy, and portal vein thrombosis to facilitate the discussion. Professor Choi, please.
Thank you for the kind introduction. I'd like to thank the organizer for giving me an opportunity to have a presentation in the APASL webinar. From now on, I'm going to present a case of middle-aged man with decompensated cirrhosis and its complications. I have nothing to declare regarding any conflict of interest. The chief complaint of the patients was abdominal distension, which was aggravated 3 days ago. A 55-year-old male patient with a history of hepatitis B cirrhosis, diagnosed 10 years prior, was referred to the emergency department of our hospital. He was on tenofovir disoproxil fumarate and was undergoing regular surveillance for HCC every 6 months with ultrasonography and blood tests. However, he did not show up for 1 year and stopped TDF on his own will. 3 days before the current admission, his abdomen has become more distended and swelling developed in both legs. In the emergency department, his vital signs were normal except bradycardia. He had jaundice, scleroicterus, and spiral angiomas. The abdomen was distended with dullness on percussion on the flanks, but non-tender. There was two positive symmetric pitting edema in the lower legs up to the knees. His initial blood test showed white blood cell counts of 7,600 per microliter, platelet counts of 41,000 per microliter, PT-INR of 2.02, fibrinogen of 97 mg per deciliter, albumin of 1.9 gram per deciliter, total bilirubin of 6.9 mg per deciliter, AST of 531 and ALT of 263 international unit per liter, sodium of 131 millimole per liter, and CRP of 4.25 milligram per deciliter. HB antigen was negative, and HBV DNA was 69 million international unit per milliliter. Investigation of the ascitic fluid showed serum ascites albumin gradient of 1.6 gram per deciliter, which was comparable with ascites due to portal hypertension. Polymorphonuclear leukocyte in the ascitic fluid was 1,839 per microliter, confirmative of the diagnosis of SBP. His MELD score was 23, and the Cliff SOFA score was 7. His dynamic CT scans and upper GI endoscopy confirmed the presence of cirrhosis, ascites, gastrolinear shunt with esophageal and gastric varices, and portal vein thrombosis in his left portal vein. We assessed that the patients had first HBV-associated decompensated cirrhosis complicated with SBP. Second, esophageal and gastric varices with gastrolinear shunt. And third, bland portal vein thrombosis. So we plan to restart antibiotic treatment for HBV reactivation, start empirical antibiotics for SBP along with IV administration of albumin, and perform endoscopic band ligation for esophageal varices. I'd like to ask a couple of questions to the speakers. First, what is the treatment choice for empirical antibiotic therapy, beta-lactams or carbapenems? Second, do we need to correct coagulation abnormalities when performing any invasive procedure such as paracentesis or endoscopic band ligation? Third, will you recommend anticoagulation treatment for portal vein thrombosis later? And if so, will you recommend warfarin, low molecular weight heparin, or direct oral anticoagulant? Lastly, what are your recommendations for the management of gastrolinear shunt? Thank you for your attention, and I will come back later with case summary.
Thank you, Professor Che, for the presentation of a very interesting case. We will go on to the first speaker, Salvatore Piano. He does not require too much introductions, but I will briefly introduce him. Salvatore Piano is an assistant professor of medicine and consultant hepatologist at Diomed University of Padova, Italy. He is currently involved in clinical and experimental research on liver disease. He has been involved in clinical trials on the management of ascites, SBP, and hepatorenal syndrome. On 2015, he has been research fellow at the Hospital Clinic of Barcelona. The result of his work has been published in many top international journals. He's a member of editorial board of Journal of Hepatology, JHEP Report, and Liver Transplantation. And he is also a member of International Club of Ascites Steering Committee. He will deliver a talk entitled The Management of Bacterial and Fungal Infections. Salvatore, please.
Thank you very much, Dr. Kim, for this kind introduction. Just a moment, I will share my presentation. Sorry, I have a problem with sharing it. Can you see the slide? Yes, I guess so. So, hello everybody. First of all, I would like to thank the APASL for inviting me to give this talk. This is the outline of my talk today. I will start with some data about the prevalence and the clinical impact of infection and cirrhosis, and then I will focus on the management of infections, mainly focusing on protocols of antibiotic treatment in patients with cirrhosis. Now, you all know that patients with cirrhosis have a very high risk of developing infections because of a certain degree of immune dysfunction involving both innate and adaptive immunity. They have an increased intestinal permeability and a change in the quality and the quantity of the microbiome that facilitate the translocation of bacteria from the gut to the systemic circulation. And there are also some clinical factors such as ascites or variceal bleeding that may precipitate bacterial infection. And as a matter of fact, almost 40% of patients hospitalized with an acute decompensation of cirrhosis have an infection at admission or will develop infection during the hospitalization. The most frequent being spontaneous bacterial peritonitis, urinary tract infection, and pneumonia. The organisms most commonly involved in infections in patients with cirrhosis are bacteria with a low prevalence of fungi, with a slight more prevalent gram-negative infection and cirrhosis. Looking at the strains, the most common bacteria involved are Enterobacteriaceae, in particularly Escherichia coli and Klebsiella pneumoniae, and among gram-positive bacteria, Staphylococcus aureus and Enterococci. Now, the problem with infection is that they have a devastating effects in patients with cirrhosis, being associated with the occurrence of acute kidney injury, hepatic encephalopathy, organ failures and ACLF, and with an increase of fourfold of 3 months mortality. And the reason for the use impact of infection is related on the interaction between bacteria and the immune system, because bacteria are recognized by antigen-presenting cells that activate the release of inflammatory cytokines. They recruit leukocytes that amplify the inflammatory response. This leads to an increase in nitric oxide and reactive oxygen species. The nitric oxide worsen the splanchnic arterial vasodilation and reduce cardiac contractility, worsening the circulatory dysfunction in patients with cirrhosis and leading to organ hypoperfusion. And furthermore, nitric oxide and reactive oxygen species cause a mitochondrial dysfunction that is responsible for the occurrence of organ failures. And the other big problem with infection is that in the last 20 years, we observed a 79% increase in age-adjusted death rates attributable to cirrhosis and sepsis. And this increase in mortality was paralleled by an increase in the prevalence of multi-drug resistant bacteria involved in infection in cirrhosis, moving from less than 10% at the end of 90s to more than 1/3 of patients in most recent reports. And this parallelism is not random, because MDR infections are more difficult to treat. They show less response to empirical antibiotic treatment, less resolution of infection, and are associated with a higher incidence of septic shock and 28-day mortality. I just remind you that the most common multi-drug resistant bacteria involved in infection in cirrhosis are extended spectrum beta-lactamase producing Enterobacteriaceae, Acinetobacter and Pseudomonas among gram-negative bacteria, and among gram-positive bacteria, vancomycin resistant Enterococci and methicillin resistant Staphylococcus aureus are the most common. Moving to the management of infections, the first step is clearly to identify infection in cirrhosis, and I want to remark that a complete workup for infection should be carried out in all patients with cirrhosis at admission, and at any time during the hospital stay when clinical deterioration occurs. And workup means to do a diagnostic paracentesis, chest X-ray, urinalysis, and to collect urine, blood, and ascitic fluid samples for culture. Then, when we have a patient with infection, we should keep in mind that the most important measure associated with a reduction of in-hospital mortality, with a reduction of the risk of in-hospital mortality, is the early administration of an antibiotic treatment that is active against the germ responsible for the infection. And this effect is independent from the severity of liver disease and the severity of inflammation. Now, on clinical ground, when we have to decide the antibiotic treatment for our patient with cirrhosis that has an infection, we have two different strategies. One is the conventional treatment that ensures coverage for the most common pathogen, but it is not active against multi-drug resistant bacteria. And to be pragmatic, it is mainly based on the use of third-generation cephalosporins or classical beta-lactams and beta-lactamases inhibitor. And on the other hand, we have broad-spectrum treatment that cover also multi-drug resistant bacteria and is mainly based on the use of carbapenems with or without glycopeptides and lipopeptides. So when we have to decide between these two strategies, we should keep in mind some criteria that should drive our selection. And most important ones are the severity of infection and the risk of multi-drug resistant bacteria. My first important message is that we do not have to waste time in patients that have sepsis or septic shock. And the reason is that any hour of delay in the administration of an effective empirical antibiotic treatment in patients with SBP and septic shock is associated with an exponential increase in hospital mortality risk. And keep in mind that even in patients with sepsis, if we are good, we are quite efficient at administering antibiotic treatment, for example, within 3 hours. But if our treatment is not effective against the germ responsible for the infection, the incidence of mortality is significantly higher. Therefore, the first important message here is that we should hit hard and early patients with sepsis and septic shock. For all the other patients, we should decide between the conventional broad-spectrum treatment according to the risk of multi-drug resistant bacteria. And we know that risk factor of MDR infections concerns local epidemiology, exposure to antibiotics before the hospitalization, and the healthcare exposure. Let me start from the epidemiology, because what we learn from the global study is that there is a relevant heterogeneity in the prevalence of MDR infection in patients with cirrhosis worldwide, ranging from less than 20% in United States to more than 70% in other centers such as India. And here, the message for the clinician is to ask to your microbiology unit a periodic report, at least yearly, to know the pattern of antibiotic resistance in your centers. As for the previous exposure to antibiotics, we know that beta-lactams use or previous antibiotic course in the 3 months before the hospitalization is clearly associated with a higher risk of multi-drug resistant bacterial infection. The issue with norfloxacin prophylaxis is a little bit more complex, with discrepancy in the literature. There is for sure an increase in quinolone-resistant bacteria, but in some studies, norfloxacin was associated with multi-drug resistant bacterial infection, while in other studies, such as the global study, we did not observe an increase of MDR bacteria in patients on norfloxacin prophylaxis. The last important risk factor for multi-drug resistant bacteria, probably one of the most important, is the contact of the patient with the healthcare system. Because you can see that moving from patients with a community-acquired infection to healthcare-associated infection to nosocomial ones, there is a stepwise increase in the prevalence of multi-drug resistant bacteria. For nosocomial episodes, there is no doubt. This patient should be treated with a broad-spectrum antibiotic treatment. This is the example of SBP. Here, patients with nosocomial spontaneous bacterial peritonitis were randomized to receive meropenem plus daptomycin or a third-generation cephalosporin, ceftazidime. And as you can see, the combination of meropenem and daptomycin was significantly more effective in treating SBP, and response to treatment was associated with a significant increase in survival. For patients with healthcare-associated infection, that means infection occurring in patients that were hospitalized in the 3 months before or are resident in nursing home residency. If you are in a center with a high prevalence of multi-drug resistant bacteria, such as this one in Italy, you can see that a broad-spectrum treatment that was in this study mainly based on the use of carbapenem is significantly more effective than the standard of care that in this study was based on the use of third-generation cephalosporins. And the broad-spectrum treatment was also found to be associated with a significant reduction in in-hospital mortality. Now, moving to our case, that is a community-acquired infection, the question is to use beta-lactams such as third-generation cephalosporin or carbapenems. Here we have a recent study from Korea showing comparing patients with SBP treated with third-generation cephalosporin or carbapenems, regardless they were nosocomial or not. And there you can see that overall there was no significant difference in survival. However, in the subgroup of more sick patients, those with Cliff SOFA equal or higher than 7, the treatment with carbapenem was associated with a significantly higher survival rate. Now the question here is, are all beta-lactams the same? Because if we have to choose between third-generation cephalosporin or carbapenems, I would say no third-generation cephalosporin. However, if we look and then carbapenems. However, if we look at the in vitro susceptibility of bacteria involved in SBP, UTI, or pneumonia to antibiotics commonly used in community-acquired infection, such as third-generation cephalosporin, piptazo, and carbapenems, you can see that in some centers, the efficacy of third-generation cephalosporin is quite low, such as in Europe, in my center, and this is almost the same in South Korea. However, with carbapenems, we have not so much advantage respective to piptazo. Therefore, for the patients of the clinical case, I would have selected piptazo. Anyway, whatever is your antibiotic choice, you will likely to use a beta-lactams, cephalosporin, piptazo, or carbapenems. And we should keep in mind that beta-lactam are time-dependent antibiotics. That means that higher the time concentration is above the MIC, higher the efficacy of antibiotics. However, from a pharmacodynamic, pharmacokinetic point of view, the intermittent infusion is not the smarter way to use these antibiotics, because you reach a peak, then the concentration decline, the subsequent administration. And these strategies may be efficient in bacteria for treating bacteria with a low MIC, but in bacteria with a higher MIC, the time above the MIC is insufficient. However, with continuous or extending infusion, you may increase the time above the MIC and restore the antibiotic treatment. We do not have randomized controlled trial in patients with cirrhosis, but we have this interesting case control study in patients with cirrhosis and bloodstream infections, comparing continuous infusion versus intermittent infusion. And as you can see, patients treated with a continuous infusion of beta-lactam show a significantly higher probability of survival than those treated with intermittent infusion. Therefore, this strategy should be implemented in clinical practice. Now, if your option is a broad-spectrum treatment and you get a positive culture, keep in mind that you should adjust your treatment according to the antimicrobial susceptibility test. De-escalation can be done, and it is safe because, as you can see, it is associated with a similar resolution of infection and in-hospital mortality when compared to patients that were kept on treatment with broad-spectrum antibiotics. And the de-escalation may reduce the exposure to broad-spectrum treatment, therefore the risk of selecting further multi-drug resistant bacteria. Now, the last point is about fungal infection. So when we could suggest an empirical antifungal infection in patients with cirrhosis? Well, I would say almost never in patients without nosocomial infection, because fungal infections are very unlikely at admission. We have several studies on bacterial and fungal infection, and almost never these infections are observed at the time of the admission. They are nosocomial. And to decide about antifungal treatment, we should also evaluate what are the risk factors. Recently, there are 2 studies that evaluated predictors of fungal infection in patients with cirrhosis. On your left side, this is a study in North America that showed that all the infections were nosocomial, and they mainly occurred in patients that already had a bacterial infection before the admission or were admitted in the ICU. The other study focused mainly on invasive candidiasis, that is the most common fungal infection occurring in patients with cirrhosis. And as you can see, risk factors were a previous antibiotic treatment, a recent episode of ACLF, previous endoscopy in the 30 days, patients having a intravenous catheter or on total parenteral nutrition, and with a length of hospital stay above 15 days. Therefore, the message here, if you have a patient with a nosocomial infection or developing a second infection and having these risk factors, you may consider to start an empirical antifungal treatment. And if you start an empirical antifungal treatment, my suggestion is to use echinocandin, because, as I said before, the most common fungal infection in cirrhosis is invasive candidiasis. And we know from study in general population that echinocandin, such as anendofungin, are significantly more effective than fluconazole in treating invasive candidiasis. So in summary, dear colleagues, bacterial infections are very common in patients with cirrhosis, and they are associated with the occurrence of organ failures and short-term mortality. I show you that the early administration of an effective empirical antibiotic treatment is the most important measure to improve survival in these patients. The protocols of antibiotic treatment, conventional or broad spectrum, should be based on the severity of infection, the local epidemiology, and the risk factor for multi-drug resistant bacteria. And as for the fungal infection, that for cirrhosis is often invasive candidiasis, you should consider an empirical antifungal treatment for those patients developing a second infection or with nosocomial infection and other risk factors such as having a intravenous catheter, parenteral nutrition, or a recent endoscopy. And thank you very much for your attention.
Thank you very much, Salvatore. He beautifully summarized on the issues of infection control in patients with liver cirrhosis. Today, Salvatore has another meeting at Babeno workshop. So we will have Q&A for his presentation for 5 minutes. Consequently, the following schedule will be delayed by 5 minutes each. And discussion time at the end of the session is shortened from 20 minutes to 15 minutes. Are there any questions or comments from the panelists?
Professor Kim, there is a question in the Q&A box at the bottom of the screen.
Okay, that is not actually for the Salvatore's presentation, but it is, what is the role of corticosteroid and plasma exchange in ACLF and in your clinical experience?
So for corticosteroids, actually the indication for me is only in patients with septic shock, in whom they are the only one in whom we have some evidence that may help hydrocortisone 15 milligram 4 times a day may improve the outcomes. Not that for plasma exchange, probably Raki and they are more experienced with plasma exchange, and probably they are the most appropriate to answer to this question.
I have a question with, can I ask a question to Professor Piano? There is a patient in the Dr. Choi presented who comes with sepsis and shock. And would you start an antifungal broad spectrum? And how many antibiotics, gram positive, gram negative, antifungal? So what will be your prescription in the emergency room?
Yes. If we are in an emergency room and the patients have septic shock, my suggestion is to use carbapenems combined with or vancomycin or daptomycin according to the source of infection. You know, if the infection is an SBP, I have experience with daptomycin, but it is inhibited by surfactant. Therefore, if the infection is a pneumonia, I would suggest to go for vancomycin or linezolid. And I would avoid antifungal if the patient is in the emergency room. It means that is community acquired or healthcare associated. Therefore, it's not very likely unless there are other conditions. It is a severely immunodepressed patient with HIV or something like that.
And if it is a patient who has come from another hospital, we know it is hospital acquired, not community acquired, then would you add drugs like colistin or polymyxin B from beginning?
Well, not in our in our center. No, we are not doing that. We usually we are now using less colistin for carbapenem-resistant Enterobacteriaceae because we have ceftazidimavibactam or veropen and varbobactam that are active against KPC. We are for this patient, if we have the suspicion of a carbapenem-resistant Enterobacteriaceae, we usually do the rectal swab, and we get the results in few hours to identify if this patient is a carrier of a carbapenem-resistant Enterobacteriaceae in the gut, because the source of infection is usually in the gut. And if it is positive, we start with ceftazidimavibactam and high-dose carbapenems. And we are trying to avoid colistin because it may be useful if we do not have another choice, but it is highly nephrotoxic.
Okay.
Unfortunately, Shiv, the problem is that, for example, for other centers here, the main carbapenem-resistant Enterobacteriaceae are due to KPC carbapenemase. That is this option, ceftazidimavibactam, are effective. But if you have a metallobeta-lactamase, such as the New Delhi metallobeta-lactamase that is spreading in particular in Asia, unfortunately, these antibiotics are not active. We are waiting for cefiderocol, that it seems the only one option for these cases.
If the patient was found to have carbapenem resistant enterobacterials in the rectal swab, what would be your choice of antibiotics?
So if I find, so you're meaning this patient is already infected and I find multi-drug resistant. Yes, I adapt the antibiotics treatment to what I find in rectal swab, because the majority of infection in patients with cirrhosis, SBP, bacteremia, or urinary tract infection will be linked to what we found in the gut.
And how about if you find Candida in the endotracheal aspirate, would you treat with the antifungal?
Well, it depends if the patient has pneumonia, because Candida may be just a contamination particularly in a patient that is intubated. Okay, and therefore, if we have clearly, abnormality in chest X-ray suggesting these patients have pneumonia, we try with an antifungal agent.
With the infiltrates, with the chest X-ray showing.
Yes, of course, yeah.
And would you consider these patients once they are on treatments as candidates for liver transplantations if the liver, organs is available and liver functions further deteriorate?
Only if the patient is improving and the infection is or resolved. The resolution of infection is needed for pneumonia. Okay. And also for SBP, the exception may be urinary tract infection. They are more easily cured, and therefore for a UTI, we could proceed with liver transplantation. But what is really important is the patient should have improved with the treatment. Otherwise, with the transplant, we will waste the organs. And
how would you prioritize these patients if the patients comes in with acute and chronic liver failure and with candidas in the endotracheal aspirates with lung infiltrate, and the patients go into coma, and whether you would prioritize the organs to such patients once you started the antifungal therapy, or you would like to wait?
I will wait. I had to be sure that this patient is resolving the infection. Otherwise, I may have done a futile transplantation.
Right, because sometimes it is really very difficult situations when you have patients with acute and chronic liver failures and with infections, and then you start treatments, and then the organs comes in, and there are other patients on the waiting list, and how we're going to prioritize, how would you define? It's very difficult. It's not just judged by the MEL scores. It's not enough.
No, I agree with you entirely. Unfortunately, we do not have nowadays a specific evidence-based tool to prioritize these patients versus the other patients on the waiting list. Now there is a large study ongoing in worldwide that was promoted by the Cliff, the CHANCE study, that is focusing on patients with chronic liver failure or liver transplant waiting list. And we hope we can try to identify what are the predictors and how we can effectively prioritize these patients.
Thank you.
Okay, Salvatore, it becomes more clear that modulation of or focusing on microbiota in infection management for patients with liver cirrhosis. Please let us know your opinion or perspectives regarding the relationship between microbiota and infection, and especially focusing on microbiota manipulation in the management of difficult infection control.
Well, no doubt that the microbiome has a huge impact. We have several studies showing microbiome abnormalities, an increase of some bacteria such as proteobacteria in cirrhosis, and these changes in microbiome are related with complications, with infection and survival. No doubt. What we really do not know nowadays is how to efficiently manipulate the microbiome. We know that fecal microbial transplantation is safe, but we do not have data on clinical impact of fecal microbial transplantation. The other way we try to modulate the microbiome is with antibiotics, but they are not the optimal choice because they may lead to resistance. We are trying to do probiotics, but the data done with, so the data we have with probiotics nowadays were not very successful. I agree that the study of microbiome and the manipulation of microbiome is a very interesting topic, but there is a lot to do before we can apply it in clinical practice.
Okay, thank you, Salvatore. Thank you very much for your time to present and discuss with the important issue of infection. Thank you. Now we will move on to the next speaker. Next speaker is Dr. Rakhi Maiwar. She's very well known to us, and she is currently working as additional professor of hepatology at the ILVS India. She has many publications and has a special interest in critical care hepatology, aka in liver disease, liver regeneration, and artificial liver support therapies. She received many awards and achievements, including AASLD Career Research Development Award in 2018. Rakhi, please.
Thank you, Professor Kim, and I would like to thank Professor Lim and the APASL for giving me an opportunity to talk about management of hemostatic abnormality in this very special APASL webinar. So I'll just highlight the few key points in the case that was presented. In this particular patient, who's a patient with decompensated chronic liver disease, this patient has sepsis. The platelet count is 41,000. Their prolonged PT and APTT and fibrinogen is low. This patient has mild renal dysfunction, some features of systemic inflammation, and a very high MEL score and a Cliff SOFA score of 7. And with this parameters, this patient also has a portal vein thrombosis and large esophageal varices. So what I'll be talking in the next few minutes is about the normal hemostasis, the interaction of inflammation and coagulation, the assessment of coagulation, and the correction. So we know about the primary hemostasis, and there is an active contribution of the platelets and the interaction of the platelets with the vessel wall. Then there is the coagulation pathway and followed by the fibrinolysis. Now, when we talk about platelets, we know that this is the most common abnormality which is noted in patients with decompensated cirrhosis. Almost 73% of these patients have thrombocytopenia, which in majority is due to hypersplenism, a decrease in the TPO production, decreased megakaryocyte proliferation, decreased marrow suppression because of alcohol, folate deficiency, and immune-mediated destruction of platelets. But despite this, there is always a precarious balance which is maintained, and there is a rebalanced hemostasis which is known in patients with chronic liver disease, because here, despite low platelets, these patients have high von Willebrand factor and low ADAM-TS13 because this is synthesized by the liver cells. If they have low coagulation factors, there's also a low in the anticoagulant factors which is synthesized by the liver, and so is the fibrinolysis which gets balanced. However, when you have a bacterial infection or in states of systemic inflammation, there is a perturbation of this balance, and this is how we should understand how this interacts and how inflammation and infection interact with the coagulation. So when we talk about infected cirrhotics, like in our case, there are a lot of things which are happening in endotoxemia. These patients are predisposed to not only a reduced synthesis of the clotting factors, but there are other abnormalities which are predispose these patients, which predisposes these patients to both portal hypertensive and non-portal hypertensive bleeding complications. So we know about the platelets. These are already reduced in these patients, and further, there could be a sepsis-induced hemophagocytosis, which is as a result of the influence of the pro-inflammatory cytokines and impaired production of megakaryocytes. So an additional insult on the marrow and an additional sequestration in the spleen and enhanced consumption due to an increased thrombin generation in septic patients with liver disease predisposes them to the worsening of the thrombocytopenia. Now, understanding the endothelium is also very important because platelets lie in very close vicinity to the endothelial lining. And what happens during inflammation or infection is that there is a disruption or damage to the endothelial cells. And this causes platelet activation. And what platelet activation does is that it further causes and contributes to the endothelial injury. The activated platelets release granzyme and other such cytotoxic granules, which causes further worsening of the reactive oxidative stress in these patients. And further, these transform into a pro-inflammatory and pro-thrombotic phenotype and contribute along with formation of platelet leukocyte aggregates and block the microcirculation. And this causes microcirculatory failure, which is seen very often in these patients. So the endothelium is a very, very important system which should also be studied. And how we can study endothelium is by measuring the endothelial function. So we can do a von Willebrand factor assay. We can measure the endogenous heparinoids. And we can also study the microparticles which are released when there is a damage to the endothelium. We can also study the ADAM-TS molecule, which is synthesized in the liver and binds with the von Willebrand factor. Now, this is an important study which was done by Madhumita at our center. And this was actually looking at the heparin-like activity or the endogenous heparinoids. As I told, these are glycosaminoglycans, and these are chondroitin, dermatan, or heparan sulfate. And what these endogenous heparinoids do is that in states of systemic inflammation and bacterial infection, they cause a heparin-like effect, and these patients get an increased incidence of bleeding complication. So in almost 145 patients of severe alcoholic hepatitis, what we saw was that 80% of these patients who had a higher level of HLE at admission, and this was studied with the help of a sonoclot assay, they went on to develop sepsis in the first week of admission. And this was also associated with high mortality and increased risk of bleeding complications in these patients. On von Willebrand factor, again, an Indian study, and this is from CMC Vellore, where they compared 3 sets of patients, the decompensated stable cirrhosis versus patients with acute and chronic liver failure. And as can be seen here, the endothelial dysfunction, which was measured by von Willebrand factor antigen and von Willebrand factor activity, was markedly elevated in patients with ACLF as compared to cirrhotic patients. And this was definitely higher in patients with liver disease as compared to healthy controls. And when they compared survivors with non-survivors, they further found that the non-survivors had rather further higher levels in patients with ACLF at the von Willebrand antigen assay, as well as the von Willebrand factor activity was high in patients who non-survive at day 28 in patients with ACLF. Now, coming to the next most important thing, which happens during states of sepsis and renal dysfunction, and 30 to 40% of patients with decompensated cirrhosis will have an imbalance of the fibrinolytic pathway. And what has been shown is that, like in our patient, there is ascites, which is grade 2. Patients with ascites, particularly grade 3 ascites patients, have hyperfibrinolysis, and this is mediated by increase in the portosystemic shunting and increased endotoxemia. And this is a recent study, and this is done by the Tom Listman's group, where they assessed the mixed fibrinolytic pathway. And what they did here was they chose patients with acute decompensation, acute and chronic liver failure, and healthy controls. And they measured the clot lysis time using the different assays. And they also checked the levels of the tissue plasminogen activator inhibitor, plasminogen, and the tissue inhibitor of fibrinolysis inhibitor. So what this showed here in this particular study was that, and this all was done using ELISA, that patients with ACLF, which was defined based on the EASL criteria, had a significantly higher levels of tissue plasminogen activator, the plasminogen activator inhibitor, again suggesting hypofibrinolysis. And this was again different between patients who were septic as compared to patients who were not septic. So a lot happens during infections in patients with decompensated cirrhosis. So then how do you assess coagulation? So we have for our patient the platelet count, which is low. We have the fibrinogen again, which is low, and the INR, which is prolonged. But what about the global test of coagulation? And this is where we are moving towards now, is that because in states of severe sepsis, systemic inflammation, there is an accelerated intravascular coagulation and fibrinolysis, and particularly this is noted in patients with high MELD score, in patients with acute and chronic liver failure, and all these factors are present in the current patient. So a global test of coagulation, for instance, a thromboelastography, and I've shown here the graph here, and what it tells us about is it starts with assessing the dynamics of the clot formation. So as soon as there is fibrin formation, this is indicated by the R interval here, and it tells us about the rate of clot formation. And then the strength of clot formation is governed by the alpha angle and the strength which reaches up to 2 millimeter. This both is measured in minutes. Subsequently, once the clot is formed, the maximum amplitude tells us about the clot strength, and this is governed by platelets and fibrinogen. And subsequently, in the first 30 minutes, what is the lysis index tells us about the stability of the clot. So you get to know the entire dynamics of clot formation, the strength of the clot, and the different factors which are responsible for impaired coagulation in this set of complicated patients. Now I'll show you some data, and this is the data from our center, a randomized control trial, and this was based on therapeutic correction based on thromboelastography as against the standard of care, and we enrolled patients who were critically ill, admitted to the intensive care unit, and all these patients had non-variceal bleed. So we randomized 49 patients to the TEG group versus 47 patients who got correction based on the standard platelet, INR, and fibrinogen level. And we also did a correction of the underlying cause, that is sepsis and uremia, for all these patients. And it was interesting here to see that majority of patients in the standard of care group required more transfusion, and 14% in the TEG group actually got no component transfusion, because here many patients had just fibrinolysis and went away getting tranexamic acid. However, there was no difference in failure to control bleed, failure to prevent rebleeds, and mortality between the two groups. Now, this is another randomized control trial which looked at the TEG-guided transfusion strategy as against the standard of care group. But here, the patients here were randomized while they were undergoing for a procedure which was either at a low risk of bleeding or a high risk of bleeding complication. So they did a TEG-guided correction versus a standard of care guided correction group, and none of these patients were septic, none of these patients were sick. So all these patients were stable decompensated cirrhosis. And see the baseline parameters of the thromboelastography. Most of these patients had a preserved parameter. And what they found again in the study was that the amount of FFP transfusion, the platelet transfusion, and any product transfusion, as we can see here, was significantly lower in the TEG-guided group as compared to the standard of care group, even though it did not make any difference in the overall survival because the number of bleeding complications were very low in both the groups. However, the number, and we can cut down on the transfusion which is given to these patients based if we go with the TEG-guided strategy. Similarly, this is again an Indian study from All India Institute, which looked at the TEG-guided blood product transfusion in context of patients with acute variceal bleed and showed that in the TEG-guided group, the number of transfusions again were limited. And we can see here that the FFP transfusion, the platelet transfusion was significantly higher in the standard of care group. However, again, the rebleeding rate at 5 days and the mortality at 6 weeks was not different. But it was interesting to see here that they showed that somehow the bleeding rate at 42 days was significantly lower in the TEG-guided group. Now, I've shown you studies on the thromboelastography in context of decompensated cirrhosis, and this is a study again from our center in patients with acute and chronic liver failure. And we know that patients with acute and chronic liver failure are distinctly different from patients with decompensated cirrhosis. So we included here 243 patients, and they were screened for sepsis, the presence of systemic inflammation, and subsequently they were followed up with thromboelastography and all the other coagulation factor assays, including factor 8, von Willebrand factor, tissue plasminogen activity assay, were all performed in these patients. And what we found here was that actually a deranged TEG or a hypercoagulable TEG at baseline was able to predict the risk of bleeding complications in patients with acute and chronic liver failure. And this also resulted in prediction of increased mortality in these patients. Similarly, this is the Western study, and here they compared thromboelastometry. So this is the first data of ROTEM in patients with acute and chronic liver failure, defined based on the Easel-Cliff definition, and they compared it with decompensated cirrhosis. And they again showed that patients with ACLF have distinctly different profile as compared to patients with decompensated cirrhosis. We can see here the hypercoagulable TEG was seen in patients with ACLF, and which means that 3 parameters of ROTEM were abnormal. And at 72 hours, this was maintained. And ACLF patients who had hypercoagulability, this correlated with the degree of systemic inflammation. And this hypercoagulability also predicted a higher mortality, both at 28 days and 90 days, even though this hypercoagulability could not guide the transfusion requirements or the incidence of bleeding events in these patients. So coming to the last part of my talk is the correction of thrombocytopenia and coagulopathy. So when we talk about correction, it could be with a therapeutic intent when your patient is actually bleeding, or when it is done prophylactically, when you're trying to prevent a bleeding event in these patients. So what do the guidelines recommend? The guidelines still do not include data on thromboelastography or thromboelastometry. What they have recommended is that we should avoid, as far as possible, unnecessary blood transfusion, because this carries the increase in the portal pressure risk. There could be an increase in the portal pressure. There could be a lot of complications associated with transfusion, including circulatory overload, lung injury, infection transmission, alloimmunization, and other reactions. So what we can take as a threshold is that if your patient is actively bleeding, go with a restrictive strategy, keep hematocrit around 7 to 8, a platelet count above 50,000, and fibrinogen above 120. And as far as possible, restrict the fresh frozen plasma. Don't chase INR, because this does not affect the thrombin generation, which is well preserved in these patients. And the 4-factor prothrombin complex concentrate, which can be used in patients where there are challenges with volume. You can use this, but again, there is a risk of thrombotic complications, and the data and the evidence for this therapy does not exist. And antifibrinolytic therapy should be given and should be assessed in these patients, because this can be very, very helpful. For prophylactic, divide your patient at low risk of bleeding or high risk of bleeding. So in this particular patient, we are looking for a paracentesis, which is a low risk of bleeding complication, and we need not correct the numbers here. And when you're considering a higher risk of bleeding complication for like an endoscopic variceal banding or any such procedures, it is where you have to go with a guided strategy. For management of thrombocytopenia, if it's an acute setting and you're transfusing, you just have to go with platelet transfusion. But when you're looking at prophylactic correction, we can use the data of TPO, we can use any of these TPO mimetics, including the L-thrombopag and the newer generation TPO and mimetics. But again, they have the risk of thrombotic complications. We can go with an interventional procedure or splenectomy in a compensated cirrhosis. For significant management of coagulation, the target of INR, which has been recommended, is 1.8, and that means every patient would be getting fresh frozen plasma, and the dose is 15 ml per kg. But again, we need to see that we have data now using thromboelastography or thromboelastometry guided transfusion. Recombinant factor 7A, there are negative trials, and Cochrane meta-analysis has also not shown too much of helpful data, but case-to-case basis, we can choose, keeping the risk of thrombotic complications. So I would like to summarize my talk by saying that patients with cirrhosis have a rebalanced state of hemostasis. Therefore, point of care test could be the best guide. A close interaction between inflammation and coagulation is actually determining clinical outcomes in these patients. The endothelial function still remains an unexplored area, and we need more studies looking at this important function in context of sepsis and renal dysfunction. And we also need larger studies, particularly in ACLF and decompensated patients in the intensive care unit, assessing the role of the point of care test for guiding the risk of transfusion, for preventing bleeding and infections. So I go back to my patients. So no transfusion. For paracentesis, But if we can do a point of care test, it can help us to guide if at all it's a grossly deranged TEG or a ROTEM, can tell us whether we need to transfuse this patient. We have to plan EVL only after the resolution of sepsis and AKI and can repeat the standard coagulation. And the presence of portal vein thrombosis in this patient, again, is a beautiful example of a rebalanced hemostasis in patients with liver disease. And I would like to thank you for your kind attention.
Thank you. Are you going on? Are you finished or?
Sorry, yeah, I finished.
Yeah, okay. The less stable rebalanced hemostasis in patients with cirrhosis, which may easily tip toward either bleeding or thrombosis, is challenged us in daily practice. Rocky gave us a wonderful talk on coagulopathy and thrombocytopenia. Thank you, Rocky. We'll move on to the next speaker. Professor Nicholas Intaliata earned his medical degree from Wake Forest, North Carolina, and complete a residency in internal medicine and 2 fellowships, one in gastroenterology and hepatology, and the other in transplant hepatology at the University of Virginia. He joined the University of Virginia faculty in 2014. His area is research interest include hemostasis and coagulation in chronic liver disease. He is one of the authors of the AASLD guidance on portal vein thrombosis, which published in Hepatology this year. He will deliver a talk entitled Anticoagulation Therapy for Bland Portal Vein Thrombosis. Nicholas, please.
Well, thank you very much for that kind introduction. I just want to make sure that, can you see my screen okay?
Yes.
All
yes.
right, perfect. Well, I would like to thank the organization for inviting me to give this webinar. The 2 preceding talks have been excellent, and this is a really interesting topic and forum. So my task is to talk today on anticoagulation for bland portal vein thrombosis. So portal vein thrombosis is an exciting area, particularly in respect to anticoagulation, and it seems to be changing almost on a yearly basis. And you can see here, the number of publications has grown tremendously, particularly over the last 5 to 10 years. I think before talking about where we are now, it's important to talk about where we started. So when we look at the history of portal vein thrombosis and cirrhosis, I think there's some interesting features. And I found this article is one of the earliest detailed descriptions from 1954. The authors looked at 17 cases of portal vein thrombosis in patients with cirrhosis, and they had some very prescient observations similar to I think where we're at in the field today. They noted that stagnation of blood in the main portal vein is probably the only constant etiologic factor of real importance, and that thrombosis, in their opinion, did not lead to any symptoms that do not ordinarily occur in association with portal hypertension, but in some cases may precipitate an acute and often fatal episode before severe damage is evident. They went on to treat some of the patients with heparin and suggest their findings that a small cohort seemed to benefit from the use of heparin by reduction of decompensation via hepatic encephalopathy. So when we look back and follow the history of anticoagulation as it relates to portal vein thrombosis, we can see that we've only had anticoagulation for about 100 years. So heparin has been around for a long time and is our oldest anticoagulant available. We had oral anticoagulation introduced via vitamin K antagonists in the 40s. And then more recently, low molecular weight heparin became available in the 70s and 80s. We'll talk a lot today about direct oral anticoagulants as these are supplanting older traditional anticoagulants. So one of the fascinating features, I think, of portal vein thrombosis are the overlaps. And so whether you're treating patients that are not cirrhotic or more often patients that are cirrhotic, there is a tremendous amount of overlap, and multidisciplinary discussions are necessary when evaluating patients for treatment options. So we've reviewed our case in the two preceding talks, and from my perspective, as noted during the initial presentation, what we have here is a patient that's quite decompensated and probably Child-Pugh C, and imaging reveals a new incidental left non-occlusive portal vein thrombosis by imaging. And so we can talk at the end of the discussion in terms of what we should do. But the first question, of course, is should we treat the patient in the first place? And what should we treat them with? So portal vein thrombosis in cirrhosis is actually quite common. Its incidence and prevalence will vary, and it will vary completely by the cohort studied. So we know that from prospective studies, it is more common in more advanced cirrhosis. And so studies that focus on patients undergoing liver transplant evaluation will have a higher incidence than in cohorts that are less decompensated. So overall, the incidence likely ranges from 7 to 16%. So what are the underlying risk factors? Well, we have to look to Virchow's triad and suspect that some role of all of these is at play here. But more recently, studies have shown that low flow in the mesenteric system is likely the overriding risk factor for portal vein thrombosis. A new study out in Journal of Hepatology by the group in Barcelona this year was a very robust prospective study who followed 369 patients over time, and they did multiple studies of hypercoagulability, inflammation, hereditary coagulation disorders, and so forth. Ultimately, they found 29 patients who developed a portal vein thrombosis, and the only predictive markers were those associated with portal hypertension and portal vein velocity. So you see there that other factors that would be associated with hypercoagulability were not predictive of portal vein thrombosis. So the decision to treat or not to treat is often challenging. And how I think of it is two categories. If the patient is never going to be a liver transplant candidate, the decision is more difficult, as the benefits outside of preserving portal inflow for liver transplantation are more controversial. And the question always remains is which one came first? So in our patient, is the portal hypertension and decompensation and slow flow in the portal vein what caused the new thrombus, or is it the reverse? Did the patient develop a portal vein thrombosis and have an increased portal hypertension and decompensation? Multiple studies, however, in the transplant literature suggest that anticoagulation or maneuvers to keep the main portal vein open for liver transplantation are beneficial in terms of transplant outcomes. Looking at the new AASLD guidance statement, they note that decisions to treat are individualized. So the clinician can make decisions in regards to the risk for the patient on an individual level in terms of improving portal hypertension or in the realm of liver transplantation. If you do not treat, you should follow very closely for extension and consider treatment if it advances. Now, as we review the literature here, I think it's important to note there are significant limitations. Unfortunately, bleeding definitions are not always used, and different studies use different definitions of bleeding. Some studies also do not clearly report the difference between portal hypertension-related bleeding, such as esophageal varices, versus more anticoagulation-related bleeding or hemostatic failure. Efficacy is also difficult to compare from study to study, as many are retrospective and use different clinical endpoints for imaging. So this is an older slide, and it details some of the studies that have been conducted in anticoagulation. Lafredo and colleagues were one of the first to publish a systematic review looking only at studies that had control groups. So they looked at studies that used anticoagulation compared to patients who did not get anticoagulation. And they found an overall recanalization rate of 71% in patients who received anticoagulation versus 42% in controls who developed spontaneous recanalization. A very nice randomized controlled trial was published just last year by Zoe and colleagues, and they studied a group of fairly well-compensated patients with cirrhosis, so Child-Pugh mean score 6.5, and randomized them to 1 month of low molecular weight heparin and then warfarin for a total of 6 months versus no treatment. They found that complete or partial recanalization occurred in 62.5% versus 34.4%. So similar findings to the previous slide. We did a systematic review for the AGA technical review, and the results are quite similar, actually. So all of the studies included were traditional anticoagulation, low molecular weight heparin or warfarin. And when we analyzed comparative studies, so again, ones with control arms, we found a risk ratio of 2.27, indicating that anticoagulation is a favored treatment to produce recanalization. When expanding the analysis to include all studies, even those without a control arm, we found a rate of complete or partial recanalization of 63%. When limiting to the comparative studies, we found a rate of spontaneous recanalization, so those that did not receive anticoagulation, of 21%. So what about benefits beyond just recanalization? So there are some signals now, I think, that there may be some other benefits. And when we look in terms of safety, we can see here in the top figure that all bleeding events in studies that used control arms, there was no significant increase overall in bleeding. In fact, there's a trend towards protective effect of anticoagulation, which seems paradoxical. However, when you further parse the data as below, the signal is likely driven by a reduced incidence of esophageal variceal bleeding when patients are treated with anticoagulation. The pathophysiologic theory there would be that if you can recanalize the portal system, portal hypertension will be reduced. However, it should be noted these are not randomized studies, and therefore bias could be driving this in patients selected for anticoagulation, may be at lower risk to have esophageal variceal bleeds in the first place, or may be treated more aggressively precisely because they are on anticoagulation. Dong and colleagues published a very similar systematic review just this year that has quite similar results. So they found in their analysis that anticoagulation therapy was associated with higher rates of portal vein recanalization when compared to no treatment. As you can see the numbers here. Overall, a slightly higher risk of bleeding in their analysis, but just similar to the previous slide, lower risk of variceal bleeding. So the concept of spontaneous recanalization is important because if a patient can get better without treatment, that is ideal. The data from the 3 previous systematic reviews ranges from 20 to 42%. If we look at the RCT, it falls right in the middle at 34%. So I think we have a good understanding now of clearly there are about 1/3 of patients who will develop spontaneous recanalization. While there are no predictors, the concept needs further study, and the only way we can do this will be future prospective randomized controlled trials to truly understand this. We also have to keep in mind that the literature up till now has not controlled for it. So the majority of the data we have is retrospective, and these studies are biased in the sense that they do not account for spontaneous recanalization in their cohorts. So if you decide to treat, the next question is, well, what should we treat with? The AASLD new guidance statement does address this and notes that the choice should be individualized. There are pros and cons to each anticoagulant. All anticoagulants to date have shown reasonable safety profile in select cohorts. And they acknowledge that DOACs are emerging, and we need to understand them in our patient population and begin to be more comfortable. So in terms of the options, as we all know, there are advantages and disadvantages. Traditional anticoagulants have more data in patients with liver disease by virtue that they are just older. However, there are issues and limitations with those medications. Direct oral anticoagulants are certainly gaining use and have some desirable features, and particularly in reversal strategies. So when we look at the literature here on the right column, I've had to expand the clinical studies for direct oral anticoagulants significantly. Where 2 years ago, we had case reports and case cohorts, we now have some prospective data and even up to systematic reviews, which I'll go through here shortly. So this slide I have to keep adjusting. So it only goes back to 2015 and is not fully inclusive, and that is because we have so many new studies in portal vein thrombosis. The point of this slide is really just to illustrate that all of the studies are different, and that makes it difficult to compare them. So by study design, duration of treatment, agent used, and outcome definitions, particularly bleeding, are different in each study. So when we compare them, we have to take that into account. One study by Lamure and colleagues in Italy illustrates, I think, a very unique and nice study design. So what they did was they retrospectively looked at 3 cohorts. They analyzed patients with cirrhosis with portal vein thrombosis on warfarin, non-cirrhotics with VTE on warfarin, and then cirrhotics who were not on warfarin. They used formal definitions for bleeding. And if you look at figure A, you would conclude that patients with cirrhosis on warfarin bleed significantly more often than patients without cirrhosis on warfarin. However, if you look at figure B, you can see that this story has more detail. So patients with cirrhosis will always have higher risk of upper GI bleeding compared to those without cirrhosis. So when we compare cirrhotics to cirrhotics, you see in the first chart that there's no significant difference whether you're on warfarin or not in terms of upper GI bleeding. However, when you look at non-upper GI bleeding, cirrhotics on warfarin have similar bleeding rates to non-cirrhotics on warfarin. So the study design shows quite nicely how complicated this really is to study in our patient population. But in this specific cohort, we can conclude that warfarin appears safe. So efficacy and safety data are based on treatment paradigms, mainly in studies looking at traditional anticoagulation in highly selected, compensated patients. Many single-arm studies do not use standard definitions and have varying treatment durations, but overall, the data are pretty convincing. They support traditional anticoagulation in relatively compensated patients with acceptable rates of bleeding. But nevertheless, DOACs are here, and it's important we talk about them. So we understand the mechanism is pretty simple. DOACs act by direct inhibition. When we look at the in the United States, the package insert guidance, you can see here that if the patient is well compensated, there are no issues. However, once the patient is child B and certainly C, we are told to avoid use. We have very little data from a pharmacokinetic standpoint with direct oral anticoagulants, as our patient populations are universally excluded from all of the DOAC drug studies. However, we have some data from Tom Lissman's group here looking at in vitro analysis using thrombin generation assay as a surrogate of anticoagulant potency. Here they demonstrated there's different potency in patients that are more decompensated. And so while dabigatran has some effect in child pug A, it has significantly more effect in inhibiting thrombin in more advanced disease. And the opposite is true with rivaroxaban. So while the data here should not drive us to adjust doses per se. It should give us pause to get more studies that can better define how we should dose these medications in our patients. Our group looked at DOACs. This was one of the first studies comparing DOACs to traditional agents for a variety of reasons, including portal vein thrombosis. Here we found that patients with DOACs had similar rates of bleeding compared to traditional agents. A very similar study was published a year later with very similar findings as well, indicating similar rates of bleeding. A very nice study just was published looking at DOACs for portal vein thrombosis matched to those who were not treated. And they found in a relatively compensated group, so Child-Pugh means 7, and followed for 6 months, that patients treated with DOAC had a significantly higher rate of recannulization with similar rates of bleeding. So the main thing people are worried about, of course, with DOACs are the safety profile. And so a lot of data has really come out over the last 2 years that is encouraging. This retrospective study by Davis and colleagues looked at patients treated with warfarin versus DOACs in a retrospective study for different indications, including atrial fibrillation and VTE. Now, the patients treated with warfarin had higher Child-Pugh status, so the groups were not equal, but overall found similar rates of bleeding. Coe and colleagues just published a systematic review looking at DOACs versus warfarin for portal vein thrombosis and found overall similar risk of major bleeding and variceal bleeding. Nisley and colleagues published it just this year, a pooled meta-analysis, and they focused on studies that included patients with cirrhosis treated with DOACs versus traditional agents with ISTH standard bleeding definitions. So just limiting it to those studies, they found that DOACs actually had lower rates of bleeding in these cohorts. However, it must be noted these are relatively compensated cohorts. Now, what about more advanced disease, such as the patient that we have? Caution should be advised, particularly in Child-Pugh C cirrhosis. We have very little data, but 2 studies have actually come out just this year. The first study pictured here is from our center by Patrick Northup, who looked retrospectively at our use of DOACs in our institution with a high rate of more decompensated Child-Pugh B and C. They found that overall, the likelihood of bleeds or having to stop therapy was much more likely in more advanced cirrhosis. This data should not be surprising, of course, but should give us pause. Data from Simler and colleagues published this year looking at DOAC use and procedural-related bleeding in cirrhotics concluded similar findings in terms of higher risk of bleeding with advanced cirrhosis. Another interesting study that makes the situation even more complex was done by Ton Listman's group and is in press in Hepatology now. They analyzed both prospectively and retrospectively the actual thrombus from explant after transplant. They found interesting findings when looking at it under the microscope, and that the majority of thrombi were manifested by intimal fibrosis, without the classic thrombin and platelets seen on microscopy. While there are some limitations to this study, it does lead credence to the clinical observation that not every patient will respond necessarily to anticoagulation. So portal vein thrombosis may be much more complicated than we initially feel. So in conclusion, anticoagulation, I think, is effective to promote recannulization with any anticoagulant. Spontaneous recannulization is a true finding, I think, in about 1/3 of cases and needs further analysis. We lack robust efficacy and safety data for all anticoagulants at this point and really need prospective randomized trials with control arms. Most studies that we have are in highly selected compensated patients. As we gain insight into underlying mechanisms of portal vein thrombosis, our approaches may shift. Thank you very much.
Thank you. As an author of AASLD guidance, Professor Intaliata gave us an informative talk on this important issue. Thank you again, Nicholas. We will move on to the next speaker. Professor Dong-il Kwon is professor at Department of Radiology and Research Institute of Radiology, University of Ulsan and Asan Medical Center. He is a very active and leading intervention radiologist in Korea. He will deliver a talk entitled Radiological Interventions for the Cirrhotic Complications. Professor Kwon, please.
Thank you, Mr. Chairman. Good evening, ladies and gentlemen. Can you see this slide?
Yes.
Thank you, Mr. Chairman. Good evening, ladies and gentlemen. My name is Dong-il Kwon from Asan Medical Center, Seoul, Korea. It's a great honor to present this topic. And today I'd like to talk about radiological intervention for the cirrhotic complications. Radiological intervention for cirrhotic complications are TIPS, BRTO, PARTO, PTO, and BATO. TIPS is a shunt creation procedure. However, PARTO, BRTO, BATO, and PTO are shunt occlusion procedures. Let's move on to the TIPS procedure. TIPS is a shunt creation procedure, usually between the right hepatic vein and the right portal vein. Varix formation is usually occurred when the photosystemic pressure gradient is more than 12 millimeter mercury. So the main purpose of TIPS procedure is to decrease the photosystemic pressure gradient less than 12 millimeter mercury. The main indications for TIPS procedure is emergency control of acute esophageal varix bleeding and recurrent esophageal varix bleeding after endoscopic treatment. Refractory ascites can also be a very good indication for TIPS procedure. This patient had acute esophageal varix bleeding. On this photography, you can see huge esophageal varices. So we successfully performed the TIPS procedure. After TIPS, you can see decreased esophageal blood flow. This patient had recurrent esophageal varix bleeding after endoscopic treatment. The rate of recurrent bleeding within 2 years after endoscopic treatment is 50 to 80%. So in this situation, we usually consider the TIPS procedure. Portal vein thrombosis, polycystic liver disease, hepatic malignancy, or biliary obstruction is anatomical contraindications, but there is no absolute technical contraindication for TIPS. However, you can consider physiological contraindications. This patient had gastric variceal bleeding. This patient also had hepatocellular carcinoma with portal vein tumor thrombi. Portal vein tumor thrombi can be anatomical contraindications, but we can perform TIPS procedure. After TIPS procedure, we can successfully control the gastric varix bleeding. Therefore, portal vein thrombosis itself is not an absolute contraindication for TIPS. On this hepatic wedge photography, you can see we can easily identify the portal venous system. Then now I'm inserting the puncture needle. This is a 16 gauge needle. After puncture of right posterior portal vein, now I'm negotiating the guide wire into the main portal vein. Then now I'm inserting the 5-branch catheter over the guide wire. Then now I'm dilating the shunt tract using the balloon catheter. And then now I'm deploying the stent into the shunt. Boring of the stent is now I'm performing. On the completion porography, you can see patent shunt flow. The technical success rate of TIPS procedure is more than 90%, and procedure-related mortality is less than 1%. Acute stent dysfunction is usually caused by thrombosis of the stent, and it is usually associated with acute angle between the stent and the hepatic or portal vein, or bioduct injury during the puncture procedure. Chronic stent dysfunction is usually caused by pseudointimal hyperplasia. This patient had acute stent thrombosis 1 week after TIPS due to the bile leakage into the stent. So to prevent acute stent thrombosis by the bile leakage, we usually use covered stent. On this photography, you can see multifocal stent stenosis due to the pseudointimal hyperplasia. In our experience, using the uncovered stent, the stent dysfunction rate was 50%, and the main cause of stent dysfunction was stent stenosis. 1 year patency rate after using the uncovered stent is 23 to 66%. However, 1 year patency rate after covered stenting is 80 to 95%. So the many investigators preferred the covered stenting. So in the practice, we usually use 6 to 10 millimeter of cover stent, depending on the pressure gradient and the patient's condition. If patient had old age, poor hepatic or cardiac function or encephalopathy, we usually use 8 to 10 millimeter uncovered stent or 6 to 8 millimeter cover stent. The location of stent is also important technical factor. The proximal stent part should be located in the IVC, and the distal part of stent should be located parallel to the portal vein wall. So the target postsystemic pressure gradient is less than 12 millimeter mercury. It can accelerate as the threshold to reduce the risk of esophageal varices rebreathing. However, gastric varices may maintain and breathe because of preferential flow through the splenic vein or other veins. This patient had huge gastric varices, so we performed a TIPS procedure. After TIPS procedure, the postsystemic pressure gradient was 11 millimeter mercury. Follow-up CT shows the remained gastric varices. Because prior to TIPS, the gastric varices usually supplied by the hepatofungal flow from the SMV and the hepatopital flow from the splenic vein. After TIPS, the gastric varices may supplied from the hepatopital flow from the splenic vein. That's the reason why the gastric vein is still remained after TIPS procedure. So the gastric varices embolization during the TIPS is important to control gastric varices breathing. There are two methods of gastric varices embolization, proximal coronary vein embolization or gastric varices embolization. Gastric varices embolization can significantly decrease the rebreathing rate. This patient had huge gastric varices, so we performed proximal coronary vein embolization during the TIPS procedure. However, after TIPS, the gastric varices were remained. So the varices embolization itself is very important technical factor. It can reduce the incidence of rebreathing rate, and it can also decrease the rate of hepatic encephalopathy after TIPS. So we usually perform BH, balloon occluded obliteration of gastric varices during the TIPS procedure. To obliterate the gastric varices, we usually put the balloon catheter in the proximal part of the coronary vein After volume inflation, we infused the scratching agent into the gastric varices. So after TIPS procedure, you can see patient stand without gastric varices filling. This patient had active gastric varices bleeding. So in this patient, we performed PATO procedure during the TIPS procedure. After varices embolization, you can see successful embolization of the varices. Sometimes we perform the left side TIPS procedure, especially in patients with atrophied right lobe or hepatic encephalopathy, because detoxified ammonia from the SMA can flow usually into the right lobe of the liver. So the left side TIPS may reduce the risk of hepatic encephalopathy. The response rate of refractory ascites is 50 to 90%. This patient had massive refractory ascites, so we decided to perform TIPS procedure. And TIPS procedure was successfully performed in this patient using the 9mm cover stent. And the ascites was completely disappeared 6 months after TIPS procedure. The incidence of hepatic encephalopathy after TIPS is 5 to 47%. Most of the hepatic encephalopathy can be successfully managed by the medical treatment. However, the refractory hepatic encephalopathy is occurred in 3 to 7% of patients. In this situation, we can consider interventional procedures. Recently, we usually use constrained stent to maintain shunt flow. This stent is an example of constrained stent. The center of stent, we reduce the diameter. So you can see the reduced shunt flow. This patient underwent TIPS procedure using the cover stent. However, hepatic encephalopathy occurred 5 months after TIPS. So we decided to perform constrained stent insertion. After constrained stent insertion, the hepatic flow was increased and hepatic encephalopathy was completely disappeared. So to prevent hepatic encephalopathy, we usually use smaller diameter of cover stent. Also, we can use uncovered stent because the encephalopathy can become clinically apparent 2 to 3 weeks after TIPS and then declines 6 months in uncovered but not in covered stent. Also, we can consider various embolization or left side TIPS procedures. The incidence of gastric varices in patients with portal hypertension is 30%, and the bleeding frequency is 3 to 30%, and the mortality rate of bleeding gastric varices is about 45 to 55%. So the complete eradication of the gastric varices as well as shunt is very important technical strategy. BRTO has become the method of choice to control the gastric varices and the portosystemic shunt. In patients with portosystemic shunt, we can occlude the distal part of the shunt, and then we infuse sclerosing agent into the shunt and varices. Sometimes we have to perform the coil embolization of the collaterals to prevent sclerosing agent migration into the systemic circulation. This patient had huge gastric varices with portosystemic shunt, so we successfully performed the BRTO procedure. After BRTO procedure, you can see complete obliteration of the gastric varices. The bleeding control rate after BRTO was more than 90%. And the long-term rebleeding rate after BRTO was less than 10%. However, there are several drawbacks of BRTO. First, there exists risk of complication related to the sclerosing agent. Moreover, balloon indwelling period was relatively long, from several hours to overnight. And sometimes repeated BRTO procedure is required, especially in patients with huge gastric varices with the portal system shunt. To overcome these potential limitations of BRTO, we invented PARTO procedure. Instead of a balloon catheter, we used vascular plug, and instead of sclerosing agent, we use gelatin sponge. Gelatin sponge is a temporarily embolic material. However, it can immediately induce thrombosis. This patient had huge gastric varices with portal system shunt, so we successfully performed the PARTO procedure. One-day follow-up CT shows complete thrombosis of the gastric varices, and the thrombosed varices was completely obliterated 4 months after PARTO procedure. So we usually perform the first follow-up CT scan within 3 days after PARTO procedure, and then we usually perform second follow-up CT scan at the 2 to 4 months after PARTO to identify the complete obliteration of the thrombosed varices. In our experience, the mean obliteration time of the thrombosed varices is 2.6 months. In our experience, the worsening rate of esophageal varices after PARTO is about 27%, and the worsening rate of ascites was about 24%. And improvement of hepatic function was observed in 40% of patients within 1 month after PARTO, especially in child A and B. PARTO procedure also can be useful in patients with hepatic encephalopathy, and we identified a significant decrease in serum ammonia level within 1 week after PARTO. In our prospective multicenter study, the technical and clinical success rate was about 99%, and the mean procedure time was only 24 minutes. So the PARTO procedure, it can induce very short procedure time, and most of the PARTO procedure can be performed within 1 hour. And PARTO does not require any balloon catheter or invasive sclerosing agent, so it is very safe procedure. The maximum diameter of vascular plug is 22 millimeter. So if the shunt diameter is more than 20 millimeter, we cannot perform PARTO procedure. One of the best indications for PARTO is large gastric varices with a shunt. This patient had very large gastric varices and shunt, so we decided to perform PARTO procedure. After PARTO, you can see successful thrombosis of the huge gastric varices. This patient had active gastric variceal bleeding. During the PARTO procedure, you can see contrast extravasation into the gastric lumen through the rupture point. However, we can successfully embolize the shunt, varices, and afferent vein. The procedure time was only 17 minutes, and we successfully controlled the gastric varices. Follow-up endoscopy imaging after 3 months after PARTO, you can see atrophied thrombosed gastric varices. So in patients with ruptured gastric varices with a portal system shunt, PARTO can be a very good indication. This patient had residual gastric varices after endoscopic sclerotherapy. On this image, you can see remained histoclear after endoscopic injection. However, we successfully filled the gelatin sponge into the shunt and remained gastric varices. After PARTO, you can see complete thrombosis of gastric varices as well as afferent veins. Endoscopic treatment usually performed in the predominant gastric varices. In this patient, we cannot fill the gelatin sponge into the remained gastric varices because of the occlusion of the varix and shunt communication by the hysterocrine. So we want to recommend subsequent endoscopic treatment after part of failure. This patient had gastric varices with portosystemic shunt as well as retroperitoneal, another systemic shunt. So we performed these shunt and varices using the Parto procedure simultaneously. After Parto, we successfully treated the gastric varices and the retroperitoneal shunt. This patient had gastric varices without portosystemic shunt. However, we identified hypertrophied left inferior phrenic vein inserting into the IVC. So we decided to perform Parto procedure through the left inferior phrenic vein. So the gastric varices were successfully treated through the left inferior phrenic vein. This patient had duodenal varices. So we successfully performed Parto procedure. After Parto procedure, you can see complete thrombosis of duodenal varices. In our long-term follow-up study, the technical success rate of the Parto procedure was 97%. And the new varices occurred in only 6.6% of patients. So all new gastric varices were developed in different sites from the gastric varices treated with Parto. So the Parto procedure is very simple procedure, and the procedure time is very short. And Parto procedure is a very safe procedure. And we can achieve successful treatment of gastric varices as well as shunt. And we also identified long-term effectiveness of the Parto procedure. So in one comparative study between the TIPS and PRTO procedure, the gastric varices rebleeding rate was significantly higher in the TIPS group, and hepatic encephalopathy was occurred after TIPS procedure in 16 to 31% of patients. Moreover, 5-year survival rate was much better in the PRTO group than in TIPS group. So PRTO or Parto is superior to TIPS regarding rebleeding rates and hepatic encephalopathy in patients with gastric varices with portosystemic shunt. In conclusion, in patients with esophageal varices, we can initially consider the endoscopic treatment. However, TIPS can be performed in patients with active esophageal varices bleeding or recurrent esophageal varices bleeding after endoscopic treatment. In patients with gastric varices without shunt, we can perform TIPS with PATO procedure. If patient has portosystemic shunt, we initially performed PRTO or Parto procedure. Thank you very much for your kind attention.
Thank you for your excellent talk, Professor Kwon. Let's move on to the last part of the presentation. Next, Professor Won-Mok Choi will present case summary.
I will briefly summarize patient progression. A second diagnostic tab at 48 hours from the start of cefotaxime showed less than 25% decrease in oxalic PMN counts, indicative inadequate response. ESBL producing E. coli was isolated from the oxalic fluid culture. So empirical cefotaxime was escalated to meropenem based on antibiogram, leading to the dramatic decrease in oxalic PMN counts after 3 days. Endoscopic band ligation was performed for the primary prophylaxis of variceal bleeding. He was discharged after 14-day hospitalization with TDF, diuretics, and ciprofloxacin for secondary SBP prophylaxis. After 3 years of follow-up, he was readmitted to our hospital because of altered mental status. Physical examination was notable for sluggish speech, flattened affect, and astaxis. white blood cell count, hemoglobin, platelet counts, prothrombin time, albumin were low, and total bilirubin and ammonia levels were elevated. HBV DNA was undetected. His hepatic functional reserve has been improved with MELD score of 11 from previous 23. While brain CTs showed no abnormality, EEG showed 3-phase waves suggestive of hepatic encephalopathy. No precipitating factors could be identified. In the follow-up dynamic CT scans, he was not on diuretics, but ascites was not observed, probably due to improved liver function, and portal vein thrombosis was disappeared due to anticoagulation treatment. However, extensive collateral vessels with a spontaneous gastrorenal shunt were still remained. So we assessed that hepatic encephalopathy has occurred due to spontaneous portal systemic shunt. Lactulose was administered as an enema, and we thought that he would be an ideal candidate for part 2. Following right common femoral vein puncture, a 6 French vascular cyst was inserted into the gastrorenal shunt. The guide wire and catheter was subsequently removed, and the vascular plug was deployed. An additional embolization with gel foam was performed until the remaining shunt flow disappeared. No immediate complications were observed. An immediate CT scan demonstrated interval complete absence of perfusion on the collaterals and gastrorenal shunt. Follow-up CT 1 year later showed persistent shunt occlusion, and his MELD score was improved from 11 to 7 after 1 year of the procedure. So let me briefly summarize the case. A middle-aged male patient admitted to our hospital because of HBV-associated decompensated cirrhosis complicated with SBP. After the complete resolution of SBP, he was discharged with TDF, diuretics, and ciprofloxacin for secondary SBP prophylaxis. Although his liver function has been improved after 3 years of TDF treatment, he developed hepatic encephalopathy associated with portal systemic shunt. He received part 2 for shunt occlusion, and he is now on regular follow without any further complaint. Thank you for your attention.
Thank you, Professor Che, for a very interesting and intriguing case presentation. I will start the discussion session. There are 2 questions from the participant. The one is, what is contraindication of anticoagulation in cirrhosis in terms of INR and platelet count? Maybe Nicholas or Raki, could you respond to these questions?
Sure. I mean, that's a good question. I don't know, if I use INR necessarily for that purpose. I think the platelet question is good, and I don't know any answer to it, honestly. I think the level of 50,000 isn't really based on much in the way of evidence, but nonetheless, it's the number that everyone seems to use for some reason. I don't think it's necessarily that predictive of bleeding risk. That being said, I think as the INR increases and the platelet count goes down, the patient almost by default will be more decompensated. So I tend to use, Child-Pugh status and, other factors such as age, fall risk, presence of lesions, prior bleeding and things like that.
Okay, the European guidelines and AA's guidelines has some difference. Do you have any comments on this question? Raki, do you have any comments about that?
Regarding the anticoagulation?
Now, contraindication of anticoagulation in terms of INR.
So I would say that, like Professor Nicholas has said, I wouldn't, and in patients with platelets less than 50,000.
50,000.
Even though, they are still prothrombotic with the portal vein thrombosis, but still I would be hesitant in using the oral anticoagulations. If I have to use, I will go with low molecular weight heparin, if at all, or consider a TIPS in these patients, which would be a more safer modality, because there is a challenge of platelet reduction, and these patients can get into major bleeding events. That has been reported in different series. So therefore, in this particular patient, I'm happy that this patient, and I would like to know what was the platelet count after the infection resolution, because that's another factor which impairs the platelet count. So if there are platelets and your manual platelet count can be checked, and if it is in the range of 60,000 and plus, we can obviously safely and monitor platelets and give anticoagulation to these patients.
Okay, thank you. Another question is, what is the prevalence of intestinal ischemia in portal vein thrombosis, including extension and initial manifestations?
Well, I mean, I don't know offhand. I think my understanding in patients with cirrhosis, you know, I think it's quite rare, honestly, because of the portosystemic shunts. My interpretation is that those are a protective factor in terms of venous outflow from the mesenteric system, as opposed to non-cirrhotic acute portal vein thrombosis, where the risk is significantly higher, and therefore the management is completely different. So, you know, I think it can certainly happen and has to be in the differential, but in cirrhotic acute portal vein thrombosis, I think it's actually quite rare.
Okay. Another question is maybe any presenters or Professor Che or Professor Lim could have replied to this question. Why did you use anticoagulation in this case? Because the thrombosis is not in main trunk of portal vein. It means that less than 50% or not complete portal vein thrombosis. Why did you use anticoagulation?
Because, you know, the thrombosis was located in the left main portal vein, so we just used anticoagulation for just short time, just one year, and the portal vein thrombosis was disappeared, and so we discontinued anticoagulation.
Yeah, maybe I also have the same question of, because the guidelines are still not fixed, whether we should be treating all portal vein, because the data shows that even prevention of portal vein thrombosis or development of thrombosis is good. But at the same time, branch portal vein thrombosis, whether they should be treated, or chronic portal vein thrombosis, where there is a cavernoma formation, whether that should be treated also, we really do not know. And I would like to hear from the other colleagues their point of view on this.
Okay. The last question from the participant is, what about using aspirin or clopidogrel for portal vein thrombosis?
No.
No.
There is no.
I typically don't. Yeah, I don't think that would
work. There are no room to use for aspirin or clopidogrel. Okay.
I did want to make one response like to you know, the decision to treat. I agree with what everyone said, and I think the beauty of this area is there is no right answer, and that's what makes it you know, so interesting to be not only a clinician but also to do research in this area. It's kind of right at the forefront, and I don't think there is a right answer necessarily. So that's why it's, you know, you have to just individualize everything.
Okay. So. Thank you. I'd like to invite questions or comments from the panelists.
Well, thank you very much. This is George Lau from Hong Kong, China. I want to ask the questions about, is there any survival data on the use of anticoagulations in the patients with portal vein thrombosis? Survival data?
Yes.
So time to event?
Yes.
Or the transplant?
Yeah, I mean, that's a good question. I think there's some data, but not you know, robust survival analysis. I think you know, one of the papers by Neary, I think in Hepatology a couple of years ago, was kind of controversial and followed patients you know, over time. and could not relate the development of portal vein thrombosis to risk of decompensation or mortality. And so their conclusion really was, outside of the setting of liver transplantation, portal vein thrombosis does not necessarily affect mortality independently. But, I think we need a lot more prospective data.
And also Professor Woon is a very nice case presentation. So was the patient ever considered for liver transplantations? Because the history is actually a few years with all the events with spontaneous bacterial peritonitis and so on. Was he ever considered for liver transplantation?
Well, yes, actually, luckily his liver function was rapidly recovered. So in the first manifestations, we thought about liver transplantation, but as his liver function has been improved rapidly, so we just followed. We just on medical follow-up.
Right, and with the procedures being performed on these patients, would it complicate any future liver transplantation if necessary? It's technically just a technical questions, because this is very amazing technical skills. I really should appreciate. And Professor Kong, could you comment on this? Whether it would affect future liver transplantation with all your procedures?
May I answer that question, Professor Lau?
Yes.
Actually, after the Parto procedure, which blocks occludes the hepatic blood flow stealing effect, the portal vein blood flow increases usually, and the liver volume and liver function improves slowly. So as shown in this case, the Baird score of this case has decreased from 11 to 7. So if the patient does not develop hepatocellular carcinoma, there would be no need for liver transplantation. And even after the Parto procedure, some of the patients may develop ascites or esophageal varicose aggravation, but the varix can be treated successfully by endoscopic management, and ascites do not last long, and we can manage the ascites by diuretics use. So happily, the patient had no need for liver transplantation.
So that's very good.
Thank you.
I'd like to invite you to China, because this is a very big technical event.
Actually, the procedure Parto was originally invented by Professor Guan.
Yes.
He's the father of Parto procedure.
And as Professor Lim commented, that tips could exacerbate, but Parto may, and BRTO and Parto may improve hepatic perfusion. Since the BRTO was introduced by researchers from Japan, BRTO and Parto was increasingly performed in Asian countries only. So I'd like to ask to Professor Guan, are there any ongoing multi-center prospective studies to compare BRTO or Parto with tips in Asian Pacific regions? Because we need a strong evidence to persuade the worldwide researchers to more perform the Parto to the patient of liver cirrhosis. You are on mute.
Please unmute.
Unmute, please. Okay.
Thank you for your question. Actually, Parto procedure, in our experience, Parto procedure is much better than the BRTO procedure in terms of technical aspect. So initially we have a plan to a comparative study between the BRTO and the Parto procedure. However, after initial experience after Parto procedure, in terms of technical aspect, Parto was much better than faster and safe. So we do not further comparative study between the BRTO and Parto. And the sclerosing agent is usually limited in the Japan. So the European country and America do not perform the BRTO procedure. So now, European country and America, interventional radiologists usually perform the PALTO procedure. So if possible, we want to perform a nationwide prospective study of the PALTO procedure. So I hope.
Okay. Maybe Professor George Lau and Professor Nicolas Intagliata could help to disseminate this innovating procedure to the world.
We actually use it a lot at our institution,
Yes.
and have both BRTO and PERTO. So
yeah,
it's
I
great.
think international communications and discussions and propagations is important. And congratulations to our Korean colleagues, Professor Kim and Professor Gom and Professor Lim, for organizing.
Thank you very much.
Thank you.
It's always nice to hear different opinions and experience.
Thank you, George. Okay, I'd like to close this wonderful webinar by thanking all eminent speakers, APASL delegates, and participants. Professor Young-Seok Lim, do you have any announcement on the next webinar or not?
Yes, we usually hold this webinar meeting on every third Friday evening in Korean time, and we expect all the attendees to come again in next month webinar, which is in the title of NEFLD. We will deal with the NEFLD in the November webinar in 19th November. Thank you very much for all the speakers and presenters, and also especially Professor Dong-Jun Kim for chairing this excellent webinar. Thank you very much.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Yeah,
Bye-bye.
wonderful webinars from Japan. Congratulations.
Thank you very much, Professor Mata.
Professor Mata,
Yeah.
thank you. Thank you very much.
김용 선생님 수고하셨습니다.
네, 감사합니다.
감사합니다,
감사합니다.
선생님들 수고하셨습니다.
네.
감사합니다.
Bye.
감사합니다.
교수님 감사합니다.
네, 수고하셨습니다.
네.